Thank you so much, Sonia. And our next presenter is Dr. Brigham, Edmund Carpenter, Professor of Psychiatry at Harvard T.H. and Director of the Social Center for Mental Health, Perinatal and Reproductive Psychiatry, Clinical Research Program at the Massachusetts General Hospital. Thank you so much, Lee, for joining us.
Sonia, thanks so much for inviting me. It's terrific to be down here at the Harvard School of Public Health. I work a few miles down the street at the Mass General. I've been there for, frankly, over 30 years, taking care of psychiatrically ill pregnant women. And I'm always sort of, as Dr. Seen commented, it's always nice to come down to the medical school and sort of talk to some real scientists. In fact, when Sonia asked me to give this talk about causal inference in pregnancy, of course, the first thing I did was look up what that really meant. Because as a psychopharmacologist who takes care of psychiatrically ill pregnant women around navigating what to do with respect to managing their illness and potentially taking medicine that either gets them well or keeps them well, I sort of jumped at the opportunity to come and speak with you today. I was going to go straight again because you guys are scientists. I thought I would go straight to a talk on registries and talk about our founding of the National Pregnancy Registry for Psychiatric Medications and show that over the life of our registry, which is ongoing, that we have this sort of shrinking confidence intervals. But I'm not going to really start there because I'm so taken away by Professor Lyerly's comments that at the end of the day, we're talking about risk assessment and sort of weighing ethics and risk in the context of trying to take care of patients who are really facing very real problems. And that's going to be the focus of my remarks over the next 15 or 20 minutes. These are my disclosures. Yes, so this is an interesting way of doing this. These are my disclosures, and these are also available at our website, womensmentalhealth.org. So I wanted to start by talking about patients. When we talk about reproductive safety and using psychiatric medications, I got interested in this work because, frankly, over 2 decades ago, we saw a shift in psychiatry, and it became very clear that women taking psychiatric medications and men taking psychiatric medications who had recurrent disease, that if they stopped those medicines, their risk for relapse was very high. And there was very little in the literature at that time guiding clinicians about really what to do in the context of this situation where women were doing well on their medicines. And in those days, we were particularly interested in antidepressants. Fluoxetine, marketed as Prozac, became available in 1987. Patients with bipolar disorder were on lithium. And it was clear that if you stopped lithium and had bipolar disorder, within 3 to 6 months, your risk for relapse was about 50%. And there was a growing interest in treatment of anxiety disorders in men and women, but it clustered in women during their reproductive years. And if they stopped medicines that got them well, risk for relapse was very high. So I became very interested in navigating that clinical space and then studying it. Because, when I trained, I was told that women were protected from psychiatric illness during pregnancy, that the hormones of pregnancy would do them well and they would just do fine. But when I started as a fellow, this small clinical service, seeing women who came in who were doing well, who were stopping their medicines, and particularly those with recurrent major depression, bipolar disorder, or anxiety disorders, what we found clinically and what we demonstrated in some of our research was that women did not do well when they stopped their medicines, and that we were really looking and we really were mandated to try to help them navigate this clinical space. This was a study that we published quite a few years ago. I think it's still the largest study in the literature, which showed in a population of women who were on antidepressants who were well at the beginning of pregnancy, if they stopped their antidepressant, they had a 5-fold increased risk for relapse compared to women who maintained their antidepressants. We showed that in depression, and then my colleague Adele Viguera showed this in women with bipolar disorder who stopped that which had gotten them well. And again, discontinuation of mood stabilizers was associated with a very swift risk for relapse compared to women who continued those medicines. Everything I'm going to speak about, and also a tremendous amount of information regarding this issue of navigating risk in this population, you can find at womensmentalhealth.org, which is the website for the Center for Women's Mental Health down the street. Our goal was never to drive care. Our goal was to see that women and their partners planning to move forward with the pregnancy, that they were empowered with the best information. And we were very struck early on in our work that when we gave patients with very similar illness histories the same information, they did very different things, and that was perfect for us. Our goal was to see that that people approaching pregnancy or the prospect of pregnancy were empowered with the best information. And so obviously we're going to use these medicines in the context of a risk-benefit decision. As I mentioned, women with similar illness histories made very different decisions. But I think that it's going to be a theme here that in a way, regardless of the information that you have in hand, the data that you have in hand, and where it comes from, whether it's a registry, whether it's from a terrific case series or a terrific series of case reports. I remember when Ed Lammer first presented those data that you presented, Dr. Rasmussen, that there's no perfect decision, and no decision is risk-free. Patients would love to know that this is the way to go, and this will lead to a good outcome in the absence of adverse effects. And we really can't provide that. We do the best we can in some type of collaborative, patient-centered model. This was from Secretary Rumsfeld from years ago, but there are known knowns. There are things we know. We also know there are known unknowns. That is to say, we know there are some things we do not know, and there are also some unknown unknowns. The ones we don't know. He had no idea he was sort of capturing this conceptual framework for thinking about reproductive psychopharmacology. But it's this sort of notion that if you have enough data and it's really good quality data, you'll come up with sort of the perfect answer, the perfect decision. And it doesn't really work that way. And I have become so impressed over the last 20 years with the private calculus that those approaching pregnancy or thinking about being pregnant on a certain medicine, how private that calculus and how different it can be patient to patient. So I'm going to talk about pregnancy registries now. And we got interested in this, particularly in the context of the treatment of bipolar disorder, but then in the context of using atypical antipsychotics or second generation antipsychotics, drugs like olanzapine, drugs like ziprasidone, drugs like risperidone, drugs like quetiapine. I'll talk to you about sort of what we've looked at. And then we expanded from looking at atypical antipsychotics to antidepressants, particularly newer antidepressants, drugs to treat ADHD, and sedative hypnotics. And we registered with on the FDA website that we were doing this which makes it, mandates, Dr. Zine was talking about the pregnancy labeling and lactation rule, that if you have a registry out there, then it has to be, for a given medicine, it has to be in the label for that medication. And so I'm just going to say a few words about antidepressants. We do, down the street, we do 1,200 consults a year about the use of psychiatric medications during pregnancy. And this is one of the most common questions that we get asked, which is about antidepressants, particularly the SSRIs. I'm not sure, frankly, that in 2023 we need registries for SSRIs. We have more information on SSRIs than we have for almost any medication that women take during pregnancy. However, we have other newer antidepressants that have become available, that have come to market, such as vortioxetine, which is marketed as Trintellix, vilazodone, and zuranolone, very recently approved by FDA for postpartum depression, and dextromethorphan and bupropion. These are new medicines where we can't practice class action teratology. It's a term one of our mentors, Cohen, Lou Holmes, used to say, the fact that a medicine is safe doesn't mean that you can just march across that whole family of medicines and assume the same risk. So this is a great example of where we still have incomplete information, but we don't have mandated registries for these in the context of post-marketing requirements by FDA. This has been referenced already today, the guidance to industry, to the manufacturers about using a multi-industry or multi-manufacturing model to gather data in the context of a pregnancy registry, but they are not mandated to do so. This becomes so, and we've actually seen extreme variability in terms of the willingness of companies and the interest in companies in supporting pregnancy registries in the absence of a post-marketing requirement to do so. And so you can see one company making two medicines where there is a PMR, and go figure they have a registry, but they may make a medicine for bipolar depression, but there was no post-marketing requirement, and we don't have a registry. And that's really problematic because we are then left with a medicine for which we have very sparse information. And so I'm going to talk about what we've done with our registry, looking at atypical antipsychotics as an example, and what a bind for the women with bipolar disorder, because the commonly employed anti-manic agents, some of them are either known teratogens, sodium valproate being a terrific example, or we've had incomplete reproductive safety data. But you saw that one of those first slides I showed you, that a woman with bipolar disorder who stops that, which got her well, she's at a very high risk for relapse. So how does that patient with her doctor navigate? We'll talk about the risk of untreated bipolar disorder. I showed you the data on discontinuation. And interestingly, while, for example, lithium may have been historically the mainstay of treatment for bipolar disorder, it really turns out that the second generation antipsychotics have become the mainstay of treatment of bipolar disorder. So we set up a registry. We had an idea that we could give this a whirl, and we did this. We started this about 10 years ago, where we were looking at rates of major malformations among infants exposed to atypical antipsychotics relative to unexposed infants. And we had a whole series of secondary aims in terms of looking at neonatal outcome and other maternal health outcomes following women prospectively across pregnancy. We interview these women at baseline, and then we follow them prospectively at 7 months, and then at 3 months and 7 months postpartum, and then obtain medical records regarding their obstetrical course as well as their neonatal and pediatric course. These are women who, again, in the antipsychotic registry, these are women who have first trimester exposure, and our control group, which is an internal control group, which is really critical to doing a registry. These are women who have a history of psychiatric illness. So in an effort to eliminate the issue of confounding, we are very aggressive about recruitment. At the conference that Dr. Seen commented on that was done in the fall, it was mentioned that registries sometimes fail because of just incomplete or inadequate recruitment. You just can't get enough numbers. And so we work very hard, and particularly using digital platforms, including social media, as well as womensmentalhealth.org that I just showed you, to engage birthing persons in this process of allowing us to follow them across their pregnancies. And I'm going to just sort of share with you. I decided sort of not to get bogged down in data, but we'll just show you for a moment. This is looking over time, and it's really a bind. Early on, we had very small numbers, but the numbers grew. One has to have sort of a commitment to doing this sort of longitudinally, and you start seeing that the confidence intervals, we see two things. The confidence intervals start getting smaller, and also there's relative stability in the risk estimates over time. And so all SGAs, we were looking at the family of medicines, so all second generation antipsychotics. And then as the registry grew, we were lucky enough to start breaking down, looking at individual molecules. And we knew that we would be, we were sort of more powered to look at the whole group and then less powered to look at the individual molecules. However, we were excited because our numbers were starting to look like, even with the single molecules, we had enough numbers to see if that drug was thalidomide, was a major teratogen. And so we've, I think that on the other side of having these data, we've really made a commitment to trying to get even preliminary data out so that the clinician can have that and can guide, as they're talking again with patients, what they're going to do. And, I was so pleased when the editor of the American Journal said, we're going to publish this even with small numbers because we think it's so important. But we hope that you'll continue to send these papers here as you get larger numbers and as those confidence intervals get smaller. Also, we're missing a whole bunch. We're missing a few slides. Well, we're missing some slides of. We've been fortunate to publish now, frankly, a very substantial number of papers at looking both at the aggregate sample, where we have sort of a better risk estimate, to looking now at the individual molecules. So, for example, quetiapine, looking at aripiprazole, so that's marketed as Abilify and Seroquel. And what we're seeing is we don't see a signal for significant teratogenicity. We see stability in terms of the risk estimate, and we're not seeing a particular pattern of malformation in the malformations that we are seeing in the exposed sample. And so I think that. Oh, this is okay. So I'm gonna go here. So we have. This is a great ad for it's a new medicine that the FDA approved, but there's no post-marketing requirement for this new medicine. So patients may be excited about this, but really very sparse information. And so I mentioned our commitment to publishing our findings. This was when we had sort of our early findings on Seroquel, on quetiapine, and then the editor allowed us to do this little pooled risk estimate in the discussion section of the paper, which they never do, by the way. We were sort of tickled by that. But to sort of see, was there consistency in the limited amount of literature that was already out there? Knowing that this sample, because quetiapine was the medicine that we were seeing the greatest representation in the registry. And then, as I mentioned, over this period of time, 7 to 10 years now, this is a study which we published looking at aripiprazole market as Abilify, and seeing sort of consistent, very modest signals of concern. And I think that when I sort of reflect on the last decade, when we had this idea of setting up a registry to where we are today, this is a very important slide because this really speaks to the necessary infrastructure to really float the boat. We published this in a methods paper quite a few years ago, but we have a scientific advisory board that governs the release of our data in terms of when was an appropriate time, which is a challenge. if you have a small number and big confidence intervals, you know, do you publish that or do you wait? And then our research coordinators and those who then go and get the actual data. We have about an 86% procurement of the actual source information from obstetrical from hospitals and then pediatric offices to get good outcome data regarding these pregnancies. And then we have those records reviewed and then send any cases of a malformation to a blinded dysmorphologist. So this is a very robust infrastructure to buoy the registry. And so I'm going to just use this and then pop back to my summary slide, which somehow ended up in the middle of this. You know, in the last presentation and some of the other presentations, what we've been really talking about is, you know, what's the model that we use to sort of most appropriately, most accurately assess risk of exposure to these medicines. And one of the things that concerns me when we were at the conference in the fall in Washington was that, you know, there was this talk about do you use a registry? Do you find some model that blends large databases with a registry, with case series? Sort of what's the perfect fit in terms of these various ways of looking at reproductive safety? And then when you look at large databases, this is, of course, Krista Hubrick's work with, and Sonia and Brian, and there's the quality of some of these data versus there's incredible variability of what is out there. And I think that that is a challenge. And so I think that what I've learned, having started, frankly, over 3 decades ago as a clinical psychopharmacologist and a perinatal psychopharmacologist, interested clinically in how to help couples figure out how they were going to navigate their pregnancies in terms of taking a medicine, not taking a medicine, stopping, not stopping. I think I've realized that there's no single post-marketing surveillance method for reproductive safety. And my hope is that pregnancy registries really will remain a central post-marketing assessment tool for reproductive safety, despite its various limitations. There are issues about small sample size, how long it takes, confounding, recruitment hurdles. We spend significant resources trying to engage women. And there are issues which I've not spoken about today, which are the people who volunteer for registries, are they reflective of the general population? And I think that given the number of new medications being used by reproductive age patients, that post-marketing requirements for pregnancy registries really should be more standard versus arbitrary. It is nothing shy of astounding to me that a medicine that got approved for postpartum depression in women who will receive that medicine 6 or 8 months out from having delivered does not have a post-marketing requirement. So I think it is going to take a partnership with our colleagues in the regulatory space, in the clinical space, in the academic space to really come up with a model that works, that gets information that's about medicines that are being manufactured to those who need it. And I think that despite some of the challenges, I think that on the other side of that conference that we had, sponsored by the, really coordinated by FDA, that we really do have a model to look forward to, which integrates high quality data from large administrative data sets with high quality data from pregnancy registries, as well as other data sources. I have a vision and I'm inspired about that possibility. So at the end of the day, when I'm in clinic, sitting with a patient who asks me, should she stop or not stop that medicine, that we can give her the most informed answer based on the best data. Thanks so much.